Good morning and welcome to Friday Chalk Talk. Today we have with us our guest speaker is Dr. Andres Calagua. He is a CL psychiatrist, that's a consultation liaison psychiatrist working at Dartmouth, Hitchcock Medical Center and Clinics. He did residency at the Icahn School of Medicine, Elmhurst Hospital in New York City, and he served as a chief resident during his last year of training. After residency, he completed a CL psychiatry fellowship at the Icahn School of Medicine, Mount Sinai Hospital. He has also received training in psychodynamic psychotherapy through a fellowship at the Psychoanalytic Institute of New England, and he is a practicing psychodynamic psychotherapist. Dr. Calagua provides embedded psychiatric consultation services at primary care and neurology clinics, and he is a consultant for the emergency and inpatient departments at his home institution. He also supervises residents and medical students at Dartmouth. And Dr. Calagua is particularly interested in HIV psychiatry, reproductive psychiatry, neuropsychiatry, palliative care, collaborative care, and psychodynamic psychotherapy. Welcome, Dr. Calagua, and you can take it away.
Thank you. Thank you very much, everyone, for being here, for inviting me. I'm very, very excited about this talk. This is a paper that I wrote when I was a fellow, actually, at Sinai. So it's been quite some time. It took a while to publish, but we started having the idea for this paper when I was a fellow. And I don't know if this ever happened to you, but this was some sort of sublimation for me because the outcome of the case was not good. This person died. I mean, he was at the end of life, but the way things transpired was like, it shook me a lot, as a trainee, to be honest with you. I didn't want it to go that way, and I had to speak a lot with my supervisor during that time. We had to process all the information that happened. And then she told me, why don't we write about this? Why don't we write about this? Let's make out something of all this, So that's how this paper came to life. This is a collaboration between people from Sinai, people from Colombia, and someone from Sloan Kettering as well. So we all tried to join our brains and say, okay, let's try to talk about this because I don't think a lot of people talk about it so often. It's more common than we expect, and people don't talk about it. And if it happens, some people are like, what do we do now with this? I mean, do we admit someone to psych when they say I'm suicidal and they're delirious? Do we send them to home hospice? So we're trying to provide a little bit of clarity, I would say, when situations like this happen in the real world. So let me give you first an outlook of the case, the patient that we saw. So this person, he was 69. He had a medical history of hypertension. He also had CHF. He was diagnosed with prostate cancer, and he had metastasis to the bone, to the liver. So he didn't have a really good prognosis. But the reason he was admitted to Sinai was because he developed some cellulitis in the face and in the nasal area. He had an abscess as well. And as he was staying in the hospital, his scars got complicated. He became more anemic. His platelets were dropping down. He was having recurrent bleedings, respiratory distress secondary to the CHF. The primary team thought that from the beginning, he had a very poor prognosis. Therefore, they called palliative care. They wanted to have a goals of care meeting for this with this person, with his family. They also wanted the palliative care input for pain management. And during the conversation with the clinicians, that's when the SI came up. He was a little ambivalent about engaging with palliative care. He didn't want to talk about medications or pain management. And then he started saying things about like, I don't want to live anymore. I'm going to kill myself. So everyone got very concerned and they said, well, let's call psychiatrists to see what they think. So when I went to see him the first time, he was very frustrated because of the pain, but also because of the lack of quality of life. He was telling me a lot of things about like, I don't want to be like this. This is not life for me anymore. I was very active before all this happened. He was also very, very cranky, very irritable. And there was some sense of hopelessness in the way he was talking, He actually told me, verbatim, he told me, would you give me something to die? Can you give me an injection to die? So he was talking about like physician-assisted death, which is something illegal in New York. And I told him, I can't do that, and he told me, well, if you don't do that, then I'm going to kill myself at home. So again, what do we do with this, right? So I spoke with him, and then as the conversation started to progress, he became more and more uncooperative. I was able to get a good amount of information from him. No prior history of suicide attempts, which is a big thing for us. No prior history of psychiatric admissions. No prior history of psychiatric treatments even. Never been on an antidepressant, never done psychotherapy. He was a frequent cannabis smoker in the past, but he actually had stopped a couple of years ago after he was diagnosed with the prostate cancer. When I spoke with him, even though he was in pain and he was a little irritable, There was no evidence of like marked delirium. He was attentive in the conversation. No evidence of dementia either. No evidence of psychosis whatsoever. Thought process was pretty organized. No hallucinations. He didn't seem to be actively hallucinating. So it was mostly the pain and the frustration stemming from his underlying medical issues. Every time that we have a patient in the consultation setting, we want to see if there's not a medical cause of the symptoms, right? If someone is a little confused, maybe the delirium. If someone is, I don't know, saying I'm depressed, I mean, are they actually having thyroid issues because of that? So he had a bunch of tests because of the hospitalization. Nothing revealing from our side, the anemia we knew about. He was hypocalcemic because of the cancer. There was some AKI, again, because of the cancer. Vital signs, BP elevated a little bit. He was sitting low, again, because of the CHF. He was with a nasal cannula. He already had some brain imaging, nothing acute, no strokes, no infections, no masses, nothing like that. And something that surprised me a lot about this person is that his family was always around him. Very big family, very big family. And they gave me a little more information about who he was as a person. So this guy used to be a truck driver. He was a truck driver for many, many years. And they all describe him as someone who was very independent, very stubborn, kind of like my way or the highway guy. And someone who valued autonomy above all things. He was very active again before the cancer diagnosis. He had to stop working after that. So there was a definite change in his life after this diagnosis. So after we had all this information, we were like, okay, so what do we do with this? I mean, what are we going to recommend for this case? The primary team was very leaning forward to sending patient home with his family. He had a big family again. Everyone was very supportive. But we really wanted to try to clarify these suicidal remarks because it wasn't something like he was saying, well, if I go home, I might kill myself. He was telling me, I am going to go home and kill myself. So it was a little more concerning for us. So we tried to clarify more if there was any sort of intent or plan behind that, but then he refused to engage, And then as days went by, he became more medically compromised. Hence, he was more lethargic. He could only have very brief interactions with us. He became more delirious. And unfortunately, after 3 days, he passed away in the hospital, surrounded by the family. Again, the family was always at his side, very understanding. The family was very understanding about why we couldn't initially say, yes, you can go home, because they understood that the suicidal remarks were somewhat concerning. They were actually concerned that because he was so stubborn, he was actually going to do something about it, because just to like say, I can do this, They were very understanding about it. But it was a sad outcome, in retrospective, I think I wish this person could have spent his last days of life at home with his family, right? But we couldn't do that. We couldn't achieve that. Now, talking about like the statements per se, like these suicidal remarks was ideation at the end of life, the diagnosis is very broad, the differential is very broad, So this person, for example, he was hopeless, he was ruminating about his condition, he was pretty frustrated, he was intermittently irritable, his sleep and his appetite were fragmented, but I think this was environmental mostly because, again, he was in a hospital, he was getting vital signs every 4 hours by the nurses, so he couldn't really sleep, But he had a strong desire to die, and he had a history of cancer, right? So usually when we have cases like this, we think about a broad differential diagnosis. The most common one is usually adjustment disorder, right? Like the cancer per se, the loss of quality per se actually causes a lot of like mood issues, sometimes behavioral problems. But you also have to think about major depressive disorder or even delirium in cases like this. I mean, terminal delirium is something very common, right? So sometimes when people are delirious, they say things they don't want to say, or because they're confused, or because they're just a little disinhibited. We also thought that maybe this could be related to some process of grief, grieving the person who he was before. And then we also started thinking about demoralization, which is something pretty common in people that have medical issues. Even though demoralization is not a DSM-5 diagnosis per se, it's something extremely common in the medically ill population. This is a table that I got from the paper we wrote, and it's basically highlighting the main features of each of the conditions that I just spoke before, kind of like give some tips about like when do you have to think about MDD, when do you have to think about delirium and stuff like that, right? So in adjustment disorder, usually the symptoms are secondary to the illness, right? And it's very prevalent in people with cancer who have meds. This is the most common issue going on in oncological patients, but the symptoms usually don't progress to the form of major depression. The main issue with major depression is that there's an impact in your functioning. right? Even if this would be an outpatient person, for example, they can tell you that I'm a little depressed, I'm a little anxious, but if there's no impairment in functioning, that's not depression. That's number one. Number two, one of the core features of major depressive disorder is something called anhedonia. The person stops enjoying everything in life, everything. Or now, sometimes this could be because of physical limitations, right? If I have cancer and pain, I cannot take walks maybe anymore. But then you could ask them, well, if you were able to take walks, do you see yourself enjoying that? And if they tell you yes, then great, then maybe that's not anhedonia. But if they tell you, I don't even think about it anymore, I have no motivation to do anything, I don't even want to watch TV or listen to music, then that's more anhedonia, right? The other difference with MDD is that the symptoms tend to be more persistent, more constant. Sometimes they can last for weeks nonstop. But in oncological patients, sometimes they can emerge as somatic symptoms, like headaches, sometimes abdominal pain, vague musculoskeletal pain. And MDD is much more prevalent in people that have advanced disease or in people with cancer that have severe uncontrolled pain. That's a big risk factor for MDD in cancer patients. Delirium, as you all know, it's like waxes and wanes. It's very common in pretty much any medical condition, right? But the acute onset is one thing that actually guides us towards thinking that someone is delirious when they make suicidal statements. The other thing is the mental status exam or interview, right? If we see someone who's like, fluctuating between the attention, like sometimes they don't like they're repeating themselves or like they're repeating our questions, so maybe that points towards delirium. Sometimes people with delirium do some sort of mannerisms when they're talking. You're talking with them and they're like doing this with the blankets, or they're doing this with their hands. Sometimes they're doing this with their clothes. So that sometimes can point indirectly towards delirium. And of course, terminal delirium is highly, highly prevalent at the end of life. Most people, when they're in their last days, they have some degree of delirium. The tricky thing with delirium is that most people think of someone who's delirious as someone who's agitated, trying to rip off like lines, trying to swing at nurses. And you also have hypoactive delirium, which looks a lot like the patient who's depressed, actually. Like physical therapy comes to their bedplace and say like, I don't want to do physical therapy. They don't want to eat. Sometimes they just stay in bed all the time. Yeah, that could be depression or something else, but that could also be delirium. And again, delirium is always like, it always has a medical cause. So again, medical workup is very important, right? Like electrolytes, renal function, liver function, TSH, and all this stuff. Constipation, a big one that we see in hospitals, especially in elderly people. Constipation sometimes can trigger delirium, not only because of the accumulation of toxins, but because of the pain, the uncomfortable sensations that you can feel. The other two that we tend to see in people that make suicidal remarks at the end of life are grief and demoralization. Again, grief is basically emerging from the sense of losing something, right? It can also be accompanied by somatic symptoms, but there's usually not clear SI. It's more of a wish, like I wish I would be dead so I don't have to deal with all this. But it's not like something like I'm gonna go home and grab a bottle of Benadryl and overdose on that. They don't have that plan or that intent. It's not really clear. And usually grief comes in waves. It's intermittent in nature and doesn't affect the functional impairment. The other thing with grief is that it has something called mood reactivity, meaning that if I'm grieving who I was, let's say I have, I don't know, ALS, for example, and I cannot walk anymore, I cannot talk anymore. If, let's say, one of my friends visits me, at least during that brief period of time when someone visits me, I spark up, I'm happy at least for 30, 40 minutes. That looks a lot like grief. Depression, you can have every single friend of yours coming home. You're still very blunted, very sad. It doesn't matter anymore. And demoralization, as I was telling you guys, is not something that it's not an official DSM-5 diagnosis, but it's something that we see a lot. There's a lot of literature about demoralization in medically compromised patients, in cancer patients, in palliative care patients. And it's basically a combination of hopelessness, helplessness, and this lack of meaning of life. And it's kind of like an existential thing, like my life has no meaning anymore. I feel like a failure. And it's very, very related to loss of autonomy. Any patient that has a degree of loss of autonomy might have demoralization. Okay. The tricky thing with this one is that if you don't detect it and if you don't treat it, and the treatment is basically psychotherapy, it can actually progress to something else like major depressive disorder. But it's highly, highly common in people that have chronic medical conditions. Now, when someone makes statements like this, you have to think about like the nature of the intent. I mean, is this a true suicidal ideation? Is this just an expression of frustration or psychological distress? What is triggering the suicidal remarks? Do they have pain? Do they have a fight with someone, right? I am psychodynamically trained, so I always try to think from a psychodynamic lens, the cases, and sometimes, it's rare, but sometimes these suicidal remarks, especially in patients at the end of life, can represent a wish to regain control over something. I have no control over my treatment. I have no control over my body. The doctors come all the time and they just do things to me. Well, this is something I can control, my words, right? So I'm going to tell someone I want to kill myself, because I actually can kill myself if I were alone, right? Or sometimes, again, from a psychodynamic lens, it's a desire to get rid of the sick part of the body, right? Sometimes people that have suicidal thoughts, they don't want to really kill themselves, but they want to get rid of something from them. I want to get rid of the depression. That's why I want to kill myself. So it's a similar thing in people that are very sick. Sometimes, in a subconscious manner, it can be actually a way to reach out for help. But I don't know what else to do. So someone can actually pay attention to my pain. I'm going to tell them that I have suicidal thoughts. It's an effort to communicate maybe with the team, right? And again, this is very, very rare, but in people that sometimes maybe have some underlying pathological character traits, suicidal remarks can actually be an attempt to inflict a sort of a narcissistic or ego blow to the clinician. Usually doctors, nurses, social workers, we're in like healthcare, we want to help people, right? We want to heal them, we want to do the best for them. But if you have someone who maybe has this attitude towards like help, like kind of like push and pull, they may sometimes want to say things like that to make you feel uncomfortable, they want to see sometimes how you react, how do you deal with that, you want to help me, well, you kind of help me and actually I'm going to kill myself, so if I die you won't be able to help me. So again, thinking about like character traits is always important in my opinion when you have this type of patients. That's why collateral is so important. I was very thankful that I had the family there to give us ample collateral, because if we didn't have them, then a lot of these pieces of information won't be available. So in psychiatry, especially, I think, and I think also in Palliative Care, collateral is extremely, extremely important. It can give you such a different differential diagnosis in the end. Now, even if someone might think that these suicidal remarks are because of frustration or because of underlying pain, I think they should always be considered seriously. You always have to take it into account, because, again, it may be because the person has depression, major depression, and then you can treat that, right, with psychotherapy or pharmacotherapy. And also because of the risk of suicide. Cancer patients, for example, like this person, they have a much higher risk rate of suicide when compared to the general population, when compared to someone who doesn't have cancer. This is especially true for cancers that are very physically limiting, like head and neck cancers or throat cancers or things like that. Pancreatic cancer, for example, even though it's like very like fast, it has a higher rate of suicide as well. Now, this is a chart that we put on the paper about like maybe how to assess, what things to ask, what things to look for when someone makes suicidal remarks at the end of life. One big question is why now? Why are you telling me right now that you are suicidal? Why not yesterday? Why not a month ago? Why now? What happened recently? I had patients that sometimes make these remarks when they had a bad interaction with a nurse or with a relative, and they're just so upset that they say like, I just want to die. So just like the timeline, I think is important. Why now? All right. And then what's the meaning behind the desire to die? Do I really want to kill myself? Or I'm just like more like I wish I could go to bed and don't face any of this anymore because I'm in tremendous pain, right? Is the aside transient? Is it constant? Does it happen every single day or does it come and go, right? And then the presence of methods as well, Are there any methods available next to you, right? Any means? Do you have a really hard intention? Preparatory behaviors. Sometimes when people are actually thinking seriously about suicide, they could do things like, for example, giving out belongings to relatives. They can give like my car to my son. I'm gonna give, I don't know, my clothes to my daughter, stuff like that. So those things sometimes can tell you things like I'm gonna donate a lot of money to a charity organization. I mean, if they're not usually persons that do that, that could be a red flag. All right. Sometimes people actually write a will, like a month before they start making suicidal remarks. That could be a red flag as well. Isolation as well, isolating from friends a lot, that could be, or moving even to a different place. I leave my house. I don't want to live with my friends and with my family anymore. I'm going to live to an apartment. Maybe that's some sort of preparatory behaviors. And then also, of course, asking them if they have a specific plan. Okay, you're thinking about ending your life. Have you thought about what you might do to actually carry on that plan? Access to guns, of course, is always important, firearms. This patient didn't have any firearms at home in this case, and then also the family and social network, like the support around them. If it's someone who has a very supportive family, like in this case, then that's a protective factor, I would say. But if this is someone who recently went through a separation, or like this is someone who was recently fired from their jobs, those are big risk factors from the social perspective. As I was saying, the evaluation of the cognition is also important just to make sure that they're not delirious. And then the prior psychiatric history for us in psychiatry is extremely important. Big risk factors is number one, prior suicide attempts, right? Because that puts them immediately high risk. Number two, active substance use. Why? Because substance users usually are very impulsive in nature. They can be disinhibited. So if I'm drinking a lot and I'm thinking about suicide, maybe one of these is when I'm really drunk, I'm actually going to kill myself. So looking for that and treating that, if possible, it's important. If someone has had multiple psychiatric admissions as well, prior diagnosis of severe refractory depression, also a risk factor. And then one thing that I like to do a lot as a CL psychiatrist is like assessing decision-making capacity. That's extremely important for me, right? So does this person have capacity, to make some decisions? Because if someone tells you, I want to go home, I don't want any treatments anymore, right? And they're making these vague suicidal remarks, okay, maybe you're not very concerned about the remarks, but can they actually go home? Do they know what that means? Like no treatment, like maybe uncontrolled pain and stuff like that. So if they have decision-making capacity, then great. But if they don't, maybe that's being caused by a psychiatric disorder. Maybe they're delirious. Maybe they're too depressed and that's affecting their judgment. Maybe they're psychotic. I don't know. So I think that's important as well. Again, as I was mentioning, untreated pain could be a big trigger for suicidal ideation at the end of life. And then I also like to explore some existential concerns, and I'm going to talk a little more about on the part of treatments, but existential concerns are very important. What do you think is going to happen after you die? What do you have any religious belief, any spiritual beliefs? Do you have some support from like a church or pastors or like spiritual guidance? What do you think happens after that? What do you think is going to happen with your family after you're not here? Right? Do you think things are going to be as usual? Is someone going to miss you? Do you think they're going to be like, oh, thankfully he's not here anymore because you were a source of conflict? So exploring that could be important from a psychodynamic perspective as well. And then the other thing is again, as I was telling you, the risk factors and protective factors for suicide. But the one important one is room for negotiation. And this basically means, do you want to try something to see if your suicidal ideation actually becomes better? If this is based on an adjustment disorder or because of major depressive disorder, there's a chance that it could happen, The tricky thing with this is the timeline, because if we have a patient that's actively dying, there's no point in starting an antidepressant. Antidepressants take like 4 to 6 weeks to kick in. So there's just no point to trying that, like logistically speaking, it doesn't make any difference. But maybe psychotherapy could be important, bedside supportive psychotherapy, So, and I'm going to use that as a segue to talk about treatment at this position, right? So what do we do with these people? Do we send them home? Do we keep them in a hospital for a week until they die? Home hospice? What can we do? So again, because of the timeline, most people at the end of life will not benefit from antidepressant. That being said, sometimes stimulants, things like Ritalin, Adderall, Vyvanse, can be given for symptom control if there's severe lethargy, because this actually may allow them to interact a little more with their family. As long as they're medically okay, as long as their blood pressure is okay, their heart rate is okay, you could try that, at low doses and see how it goes, right? Antipsychotics, maybe if there's some sort of delirium, and the reason behind the antipsychotic is, again, engagement with family. You want to make them comfortable. And sometimes when someone is hallucinating or is very paranoid, that's super uncomfortable. It's scary actually. So an antipsychotic can help with comfort care as well. Pain management, again, I want to highlight this, is extremely important for us. It's a must for us. The idea, even though it's tricky, is to aim for maximum pain relief without over-sedating the patient. Again, because sometimes you want to talk with them, about how they're doing, like mood and stuff like that, and because you also want them to interact with family. And one important thing for me as a CL psychiatrist is taking into account the physical symptoms and the medical history when prescribing a medication. Because antipsychotics, antidepressants, even though they're good medications, they have a bunch of side effects, right? So if someone is severely hyponatremic, for example, I maybe wouldn't give an SSRI, right? Because that could actually worsen hyponatremia. Or if someone has, I don't know, active atrial fibrillation, maybe it's not the best time to give an antipsychotic right now, right? So, or if someone is having a lot of respiratory depression, for example, maybe I shouldn't give an antipsychotic or a Benzo. Maybe I could do something else instead of that. So taking into account the physical condition is also important. These are two types of therapy, dignity therapy and short-term tailored meaning-centered psychotherapy, that I actually didn't know about before this case. And I started reading about them, and it's actually pretty cool and pretty interesting. You can tailor this a lot to each case, but basically dignity therapy is when you have someone who has some sort of like therapy training and they try to collect the patient's life story, so to speak, like a life narrative, I don't know if you ever done that, but it's very interesting. It's very emotional too. But you start talking with them, you get to know the person a lot, it's kind of like a crash course of psychotherapy, intensive psychotherapy, right? Like, who are you as a person? What do you used to do? What was the role you played in this life? Were you the head of the family? Were you someone who was more on the sides? What did you accomplish? Do you have any regrets? Do you think there's anything you would have wanted to do before this? Anything you want to tell your family before you pass away? That's super important to bring some sort of closure. And then when you have all the information, you put this on this paper called a legacy document. And then actually you sometimes can actually present this to our relatives. It's very, sometimes people even record it. Sometimes I've seen people recording videos of this. It depends on the family and the patient as well, but just having some sort of document that functions as the legacy of the person is pretty important. Meaning-centered psychotherapy is a little more complicated because this was originally created for outpatient settings, long-term, like 8, 12 visits, in group settings. But there are some studies saying that very short, brief, tailored, meaning-centered psychotherapy could actually help patients at the end of life. Again, the idea is to share meaningful experiences with a therapist, right? Like, who were you before the disease? Any traditions, the cultural background, religious background, prior attitudes towards suffering, coping mechanisms that were helpful in the past. And then also trying to share this with the family, have the family input for this. So these are brief things that you can do if you have someone that's suffering a lot, psychiatrically speaking, at the end of life. Now, what do we do with this person? What do we do with these patients? Most of them will not go to a psych unit. It's really, really rare, unless you have a med psych unit to take someone at the end of life. But even if you have a med psych unit, you usually don't admit to psych because, again, there's an expectation of a brief lifespan. They're usually very medically complicated. And also because, again, you want them to spend time with family and loved ones. I'm not going to deprive someone from spending time with their kids, their parents, just because they are psychiatrically unstable. I don't think that makes any sense. Also remember that if you go to a psychiatric unit, it's not like a medical unit. There are a lot of limitations, including visitation limitations, right? You cannot see kids, for example, in the psych unit. You cannot have your cell phone all the time with you to FaceTime with someone in the psych unit. So it's very limiting, very restricting. So I usually don't think this is the best idea, unless you have someone maybe who is not at the very end of life. Maybe they have like 6 months to live and they're medically stable and they have a 5 or 6 prior suicide attempts, well-documented history of treatment refractory depression, and they're like having a new bout of depression. Maybe in that case, you could actually entertain a brief admission, right? But if there's someone who's very, very sick, and about to die like within a week or two, expected, I don't think this is a good idea, really. You can always provide psychiatric care in a medical unit. That's why we have CL psychiatrists. So you don't need to go to a psych unit to provide psychiatric care, right? And then the other option is home hospice, right? Home hospice is something very interesting. I don't think a lot of people know about home hospice, but it's a really good option. But I think that for home hospice, you want to have a family that's very on top of this, a reliable family, because you rely a lot on family. The home health aid hours are very limited, so there are some times where the family will need to be the one providing medications, or maybe like, rotating the patient in the bed. So they have to be physically, but also emotionally capable to provide this care to the dying patient, right? Now, if a patient is verbalizing active SI, meaning that, like, I'm gonna go home and jump from a roof, or I'm gonna go home and grab my gun and shoot my brains, I wouldn't send those patients to home hospice. Why? Because it's too risky. Because if you send them to home hospice and then somewhere along the line they're actually able to complete the suicide, this is highly traumatic for the family. A lot of guilt associated with that, saying like, well, I shouldn't have accepted that. I mean, it was my fault because I was supposed to take care of them. So it could be pretty traumatic, right? But again, this is only for active SI with a plan and with clear intent. And maybe someone who also has a high risk factor, like prior suicide attempts, prior well-documented history of MDD and stuff like that. Again, if the SI is more of a manifestation of frustration, anger, and there are very few risk factors for suicide, you have an involved, supportive family, home hospice should be considered. Now, the last thing I will say is, like, for home hospice, this is something that the conversation should happen before the acute event, I would say, just to like have everything set up. It's like advanced directives, right? No one thinks about them, and then when things are like going south, they're like, oh my God, what do we do now? I think the same thing would be with home hospice. If you have a patient and the prognosis is already grim, having these conversations with the family and with the patient and themselves, I think it's also important. Just know what are their preferences too. Just like the fact of, I mean, talking about autonomy, quality of life, you want to give the person some autonomy. Like, this is what I want to do, and this is something I don't like to do. So having the conversation beforehand, I think is pretty important. All right, and that's all I have today. I'm happy to answer any questions or comments you may have. I don't know. Let me just stop sharing my screen.
Ruth, before you go, I just want to ask one question of Andres. You know, in your paper, you have the regret of the patient not making it home where they wanted to go. What do you think you would have done differently? Unless I took your question, Ruth. But what would you have done differently if you could, go
This
back and
person?
make a change?
Yeah,
Yeah,
I think I would have sent him home with the family.
yeah.
I would have done that. Yeah. The family was extremely supportive, I'm talking about like the sister was there, the brother was there, his kids were there, his grandkids were there, the in-law, the daughter-in-law, the brother-in-law were like very, very, very involved as well. So it was a big family, you know. This is someone who had a lot of people supporting him around. Every single day when I went to his room, at least 3 or 4 persons there sitting with him, even if he was like not talking anymore, just there with him. So that was pretty touching for me. And again, I wish I could have actually sent him home. If I could have done that, something different, I would have sent him home. I don't think he was a high risk patient. He didn't have any history of suicide attempts. He didn't have any prior psychiatric admissions. The other thing I would say about like SI at the end of life is like you also have to think about the physical component. If someone is physically limited and they tell you I'm going to jump from a roof, that's highly unlikely, right? They're not going to have the strength to do that, right? But again, when there's a will, there's a chance. So you gotta be cautious, especially if there's some specific intent or plan. In his case, one of the things that prevented me from saying, yeah, you can go home was like he was very vague when talking about a plan. He was like, well, I'm not gonna tell you because then you're gonna stop me. So I was like, I wish you would have you didn't say that, but you did. So it was really hard for me. Um, there was a lot of affect, in the case, involving the case, also with the primary team. It was hard. It was really hard.
Thank you so much for sharing this story. I really appreciate it. Wish we had an hour to keep talking about it too.
Yeah.
I appreciate the way that you were with him and also how you were you really cared about the family. You didn't want them to have to deal with if he did decide to take his life when he was at home. And so I appreciate that. That shows just a lot of care and concern for them. So my question, very similar to Maureen's, like what you would have done. But I was curious, the way you described his death with the family all surrounding him. And it was just 3 days later. So it was a very short amount of time. Why that was unfortunate, because it sounded beautiful. And I'm a chaplain, so.
Yeah, I mean, I think like if you see it from your point of view, like as a chaplain, I mean, I think it wasn't a bad death. He wasn't suffering, he was, I mean, when you're delirious at some point, you just like, you're like morphine and pain control, so you're just like slipping away, right? The family was there, it was kind of like a celebration of life in a way, I would say, but I think the outcome was sad for me because I wish this could have happened at home, not in a hospital, where you have nurses around and they're not part of the family. That's the reason I felt it was a little sad, and I tried to, I mean, I tried so many times to engage with him again, like I would go in the morning, I would go in the afternoon, and I would go later before I was leaving, and again, the family was always there and they were actually very appreciative. They would tell me, I can see you're trying very hard, but he just either A, doesn't want to talk with you, or B, he can actually not talk with you anymore. Yeah.
Looks like Marty has a question too.
You know, my case is about, or my question is about exactly what you brought up, that he kind of shut down quite a bit. And just like psychiatry, palliative care, my skill set is when somebody's willing to engage and explore the why with me. Looking back now, do you have a guess as to why he shut down? Something you could have done differently? Was it an approach? Is there some tips you could offer us to make it more likely that somebody will engage in these really tough conversations?
Yeah. I think nowadays there's still a lot of stigma about psychiatry, about like if a psychiatrist comes and speaks with me, that means there's something wrong with me. I'm crazy, I'm nuts.
Mm.
And, this person was a very traditional person. Like, just to share a little more information, he was Hispanic as well. Like, I'm Hispanic, so there's a lot of stigma in the Hispanic community about mental health even nowadays, But be mindful that this was someone who was 69. This was someone who was raised in a different time. So when I came to see him and I told him, hey, I'm from the psychiatry department, he was like, what do you mean you're from psychiatry department? So I think it's always good to identify yourself, but maybe sometimes guiding the question more into a conversation than a psychiatric interview could be helpful, Because sometimes we as psychiatrists, especially when we're trainees, we're very methodical, right? I need to know if you have psychosis. I need to know if you have prior suicide attempts. I need to know if you have anxiety and blah, blah, blah. And yeah, that's good if you get that information, but it's always, I think in cases like this, when someone is having suicidal remarks, it's more important to actually converse with the person and say, hey, what can I do for you? What can we do for you right now? I mean, forget about like medications, forget about psychotherapy, just be with her, like hold their hands maybe, do you need something? You need me to like put your pillow a little higher, And then the time is important, you have to be willing to spend time with them. If you're in a rush, they're going to feel about it. They're going to feel that you're rushing, So you gotta, I mean, it's hard nowadays in these times where everyone's rushing and everyone's like running around, but you gotta have the time, You gotta have that compromise about like spending time with them, like an hour at least, just to get a sense of who they are, You don't have to ask them about like, are you suicidal right now? Yeah, maybe you can explore that at some point, but that's me, I mean, when were you diagnosed with this cancer,
Sure.
How did your life change after the cancer? Anything that you missed from before, a little bit of like dignity therapy maybe, or like meaning center psychotherapy, what do you think is going to happen after you die, Do you think you're going to die soon? Do you think it's going to take you some time? And then maybe, once you have a better rapport, maybe then start to explore a little bit more about the suicidality. It's tricky. I think it's case by case. But if I could go back in time and do something different, I think I would have done my interview a little less structured, a little more like freestyle, just to get to know who this person was better. Because the reason I know all this information was because of the family. He didn't share that with me. He didn't tell me he was a truck driver, He didn't tell me that he was very stubborn. Like, it was the family who told me this. So I wish he could have shared something like that with me, At some point when I came speak with him, I thought like, well, maybe because I'm Hispanic, we're going to have a special connection. That didn't happen. Didn't happen, So everyone's different, Everyone's just different.
Yeah, that reminds me. When I read your paper, it reminded me of a quote. The crummy part is I cannot remember who wrote this. I'm 99% sure this is probably a Harvey Chochinov quote because almost everything I read about this is from him. But it's the single most important response a clinician can offer to their patient is a willingness to engage in this discussion about wanting to die. It shows that such conversations are acceptable and opens up a richer dialogue. And because I mean, so often I've seen somebody share something like that, and then somebody poo-poos it, right? Says, oh, you can't talk about that, or we don't do that here, or that's not legal in this state. And maybe that is part of the conversation eventually, but that cannot be your opener. I mean, it's got to be, I'm a human being too. Thank you for sharing so much. Can we sit down?
Exactly. Yeah, I agree. I mean, sometimes I see patients in the outpatient setting, and I ask them about suicidal ideation, and they're like a little hesitant to talk about it because they have the idea if I say yes, I'm gonna end up in a psych unit. It's not the case, and I tell them, I think everyone in their lives, at least once in their lifetime, has said like, "Gee, this is a lot to deal with right now. I wish I could go to sleep and never see anyone again, or I wish I could escape from this situation." I think we as human beings, at least once in our lifetimes, have thought about that, even if it's a fleeting thought. So that's what I try to tell them, it's okay if you have a thought, but we can talk about that, to see if the thought is very intense, very persistent, and then from then I get the other information about like risk assessment or like prior suicide attempts, prior depressive episodes, access to lethal means, substance use, and all this stuff.
Yeah.
Yeah. Yeah, of course. Yeah. And
That was great.
I read a question on the chat about like if the location doesn't offer dignity therapy or MCP, I'm gonna send you, Marty, some information because there are actually manuals for MCP, like self-guided manuals, that you can actually use, Yeah,
Okay.
so they're very common, so I'm gonna send you that information too, so you can have it by email.
All right, I'll pass it along then too to
Awesome.
the audience. Yeah.
Thank you.
Well, thank you, Andres, and thank you for all this great information. I think we all have had instances in which we've had patients say, "I just want to die," and so it's good to know how to more in-depthly, delve into what's going on with them. And you've given us some great tips. So thank you. And thank you everyone who joined us. Happy Friday.
Thank you. Thank you for inviting me. It was a pleasure having you. Thank you so much. Have a good day.
Thanks. You too.
Bye.